Thank you, Prem. In spite of your bad throat, you are able to come and give a beautiful lecture about the various ECG features, including how to diagnose MI in LBB, paced rhythm, and also LVH with the case examples. Now, to add one more point, addition to that, changes in the inferior lead as well as anterior leads, not only the wraparound LED, but also when the LED is occluded distally, you can have a ST elevation in inferior leads as well as anterior leads.
Yeah, the first slide you were saying, I think you have put 60% sensitivity or what?
Yes, sir. That's what.
Yeah, so that's the most important point. Don't trust the ECG alone.
Yes.
The history's got to be the most important risk factors, what kind of presentation it is, and serial ECGs. Many a times we would have seen classical chest pain ECG normal for 24 hours, 48 hours, and then suddenly a change comes back. The important thing is always compare a previous ECG with the present ECG. Any changes going on, acute coronary syndrome, and especially when the ECG is normal and patient has got a classical pain, you have to rule out left main. That's a sudden death and all is really associated with it. So we have to keep a watch on that. So, anybody else want to say?
Any queries from the floor? Yeah.
Practicing in a rural area is sometimes challenging, really challenging. We have very nice equipment in corporate hospitals, GE machines, Philips machines, whereas in rural areas you get ECGs from government hospitals where they don't take care of standardization. That's what I would like to tell my colleagues over here. Many a time the standardization is not correct, and either they get a very small complexes or very large complexes, and the medical officer there gets frightened and he refers it immediately as MI. So my suggestion to my colleagues is check the standardization every time, and also check your machines if the standardization is correct. 2. I've had many occasions where the patient comes with severe chest pain, classical angina, ECG is normal. When my echo shows classical hypokinesia, do I need to thrombolize?
Yes, sir. When you have an evidence of ischemia, and especially in the periphery setting, definitely thrombolysis is definitely going to help you, because I mean, this is what even way back in when Jayadeva, also my professor, used to teach me. He will say even for NSTEMI you thrombolize if you are not able to go take the patient to the cath lab. You assess the bleeding risk. If his bleeding risk is low, please thrombolize. Whatever burden of thrombus which is there, it is going to be reduced by the time you shift to the patient to a cath lab center. So when you have a documented evidence, probably this, especially the circumflex occlusion, sometimes it's very silent. You're not able to pick up in the ECG, or you may sometimes have to take a lead above or below, or you have to take posterior leads. If the patient has got a classical chest pain with a hypokinesia, then it's definitely an acute coronary syndrome. Slowly it may start evolving. You can very well thrombolize in the early stage.
Nobody's going to question me why you thrombolized a normal ECG.
I mean, if you don't have a cath lab in a center, nobody is going to question us for thrombolizing. I think when you have a documented evidence of a wall motion abnormality also.
Thank you. Thank you, Prem.
Good presentation, Prem. Sir, actually for your, recently we had a patient in our GH. The patient was not thrombolized, and the patient got developed via ventricular septal rupture next day. So the complications, if we are not thrombolizing, means the complications are more deadlier. Yeah, and for an information, the persistent ST elevation even after complete revascularization, look for pericarditis. We have to look for atypical pain, these pains and all. We miss pericarditis more for. That's the for information. Thank you.
Thank you, sir.